So today I'll be talking about the intraoperative radiological landmarks for lumbar spine instrumentation. So before we start, we should know the type of instrument that we are dealing with. We have the X-ray tube on the lower half, the image intensifier on the upper half. The X-ray tube has a collimator which adjusts the beam of the X-ray, and we have a display monitor for this. Uh, an important aspect of this is to know about something about radiation safety. As soon as you double the distance between yourself and the tube, you actually reduce the scatter radiation to yourself by more than one fourth. So this is the inverse square law. The X-ray tube should always be preferably on the lower side, on the underside, to avoid the scatter radiation to the head and neck region of the operating team. Effective communication with the radiology technician is extremely important. We know that lead protection improves the radiation safety. You should increase the distance between you and the tube, bringing the image intensifier as close to the patient as possible, using the collimator to decrease the size of the beams and decrease the zone of radiation. KV needs to be increased in obese patients to improve the quality of the image, but this also increases radiation. And MA increases the density of the image. Pulse fluoroscopy is something which should be preferred over continuous or live imaging, but because this has shown to decrease the degree of radiation by more than one fifth. So pedicle anatomy. So pedicle simply is the part of the bone which connects the vertebral body with the posterior elements. In the upper lumbar spine, the transverse medial angulation is about 10 degrees, whereas lower lumbar spine it's more like 20 to 30 degrees. The craniocaudal angle is usually parallel to the superior end plate, and screws are typically 70 to 80% of the vertebral body. So there are three methods of lumbar pedicle location and orientation: the Roy Camille, Magrel, and the Weinstein method. The one which I use is the Weinstein method, where the entry point is at the lower lateral part of the superior facet and the transverse process. So this is the entry point. This entry point corresponds to 3 o'clock of the 3 o'clock of the pedicle on the 2D fluoroscopy image. The chances of injury to the adjacent superior facet are the least with the Weinstein method, and that is what I prefer. So indications are well known to everyone for pedicle screw fixation. So there are mainly two methods: navigation guided and non-navigation guided. Non-navigation, we will be concentrating today on the fluoroscopy methods, mainly the AP fluoroscopy and the Magels or the owl's eye view. So the most important thing before instrumenting or before placing a pedicle screw is to get a good C-arm image. So we usually start off with the AP image, where there should be a proper squaring of the vertebra. Squaring of the vertebra means the upper end plate and the lower end plate should be completely parallel to each other. The spinous process ought to be equidistant from the pedicles. The pedicle should be oval, and the transverse process should also be identified ideally. Once this clear X-ray is identified, the vertebral level of interest usually dock at the 3 o'clock position of the pedicle on the left side, and then using a gentle corkscrew method, we proceed forwards. For usually obese patients, we know, especially for percutaneous screws, the distance from the midline has to be larger compared to a thin patient. Once you reach the medial edge of the pedicle on the AP fluoroscopy, we turn the machine and get a true lateral X-ray. Again, the true lateral X-ray, the upper and the lower end plate should be completely parallel and should be seen like this. On lateral X-ray, you should have crossed the posterior vertebral line by this time. Also need to be kept in mind that you should not reach the lower part of the pedicle, since that's where the root is, and you can have a root injury there. Once that is done, this is basically a fluoroscopy of the percutaneous method. So here we put in a K-wire, then over the K-wire we put in a tap. Once the tap is done, we take the appropriate size screws and place our screws, and then place our rods. And this is a T-lift patient for a grade 2 spondylolisthesis MIS technique. This is again a T-lift following the same steps of of fluoroscopy and principles of pedicle screw fixation. Now let's come to the owl's eye view. It has many names: oblique view, Magel's view, Scotty dog view, and the pedicle axis view. The pedicle axis view is probably the most appropriate name, since this view of fluoroscopy gives direct access to the pedicle. We can estimate the degree of tilt that is required in the fluoroscopy by a pre-op CT or pre-op MRI. As you can see in this image, the left pedicle axis is about 30 degrees from the center, and the right pedicle is about 20 degrees from the center. So we know that this is how much we are going to need to tilt the fluoroscopy unit. So this is, as I told you, another name is a Scotty dog view. This is a Scotty dog view. We should be like modern day Arjunas, where we just look at the eye of the Scotty dog, which is the pedicle. Uh, we do not look anywhere else. We may need to make sure that we always remain within the confines of the cortical margins of the pedicle when we are using this method. So this is how the C-arm is tilted to get our pedicle axis view. So this is the degree that we have usually calculated beforehand based on our CT or on our MRI. So this is how the machine needs to be placed in a patient. However, this is not the right way to take the image, as we have shown in the previous part, from the point of view of radiation safety, since the X-ray tube needs to be under the patient and not above the patient. So this is another L4, L5 listhesis with spinal stenosis. So this patient also, we did a T-lip using the same pedicle screw fixation. This is another application. So this is an osteoporotic fracture of the T12 with paraparesis, elderly patient. Again, all the principles of pedicle screw fixation remain the same. Start at the Weinstein's method. Start at 3 o'clock on the pedicle, and then get our screws in place. Here we also did a vertebroplasty for this patient. This is the intra-op images, and this is the final product. So for S1 pedicle screws, the entry point is usually just lateral to the superior facet and the junction of the ala, where you basically point towards the promontory and try to get a bicortical purchase in these screws. As you can see in this image, bicortical purchase of the S1 pedicle screws is important to have a good biomechanical strength, especially in long constructs like this. This is another patient, very complex deformity, kyphoscoliotic deformity, secondary to segmentation anomaly. 14-year-old boy. We had to do not one but two levels of completely posterior vertebral column resections, osteotomies, and then place in our screws to achieve this kind of reduction from T4 to L4. Another method of lumbar spine instrumentation, which has recently gained some popularity, is the cortical bone trajectories, described first by Santoni in 2009. The main advantage of this method is that it engages four cortical surfaces, and biomechanically it has been shown to be either equal or better than conventional pedicle screws. So I think of cortical bone trajectory screws as the lateral mass screws in the cervical spine, where the screws are directed superior and lateral. The entry point on the left for the left side pedicle is usually at 7 o'clock of the pedicle, which is basically at the junction of the medial edge of the superior facet and the inferior most edge of the transverse process, and you direct yourself to go from the 7 o'clock position to 1 o'clock position on the left sided pedicle, and this is the end product. How this looks like. As you can see, these screws are smaller than the conventional pedicle screws, but biomechanically have been shown to be as good or as effective. The main advantage is that you don't need to do dissection too laterally, especially in obese patients and big patients. You can just do your central midline exposure, and you will have your entry points identified there and there itself. So this method is obviously contraindicated for patients who have pars defect or significant deformity. So this is a kind of a algorithm which I would recommend to all the youngsters in the crowd. So you need to start off with obviously board models, cadaveric workshop, experience assisting with the senior surgeon. So first need to master the lumbar pedicle screws in the open method, and then probably go to thoracic methods, T-lifts. Obviously, deformity is at the top end of the pyramid for pedicle screw fixation. So my take-home message: need to have a good X-ray technician. That is extremely important. Cannot emphasize this enough. Enough. You should have an good X-ray interpretation as well. You start and master the lumbar screw pedicles first. Upper thoracic and sacral screws are usually more difficult and can be mastered later. A study of the pre-op CT and X-ray is important. We start with deformity and we start with trauma and degenerative cases first. Tumors and deformities always come later. There should be a concordance when you're beginning. There should be a complete concordance between anatomical, radiological landmarks with the tactile feedbacks. In deformity, you have an additional measure of safety in form of the direct electrophysiological stimulation of the pedicle screw to see if there is any breach there. Radiation safety obviously is extremely important. You need to stand at least 10 feet away from the flow unit with adequate PP protection. Thank you very much, and I'll be happy to take any questions. Thank you.